There we go. Slideshow. Hello, everyone. My name is Anastasia McKibbon. I am an RN case manager here at YoloCares. I have my bachelor's in the science of nursing, and I am also a certified wound care clinician. Today, I will be going over some basic wound care 101. So what causes a lot of the common types of wounds, what to look for, basic treatments, and prevention. So what is a wound? A wound at its basis is when the skin breaks down and loses its ability to protect and function. There are lots of different types of wounds. They're usually caused by a variety of reasons. Some of the most common that we see in the older population are pressure injuries, pressure ulcers, skin tears, abrasions, lacerations. You also do often see with folks who have poor circulation or heart disease, you see venous stasis ulcers and arterial ulcers. Today, we're going to be mostly focusing on pressure injuries and pressure ulcers, and then also skin tears / abrasions, because those are the most common and the most easily looked at and recognized. And some of them you can treat at home, but as a caveat, always seek advice and information from your primary care provider if you have any new wounds come up or any concerns about existing wounds. So first up are pressure injuries / pressure ulcers. You can hear them referred to as either or both. They are some of the most common types of wounds, particularly in folks that are older, have impaired skin integrity, or have decreased mobility. They are usually caused by prolonged exposure to pressure or friction on a pressure point or a particularly bony prominence. So a bony prominence is where you have like your hip bone or your tailbone. They have more pressure on them when you're lying flat or sitting, and those are some of the most common places that you find those. They can occur at any site. They vary in location. They also vary in size, depth, and severity. As I said before, your patient or your loved one is more at risk if they have poor nutrition, decreased mobility, so wheelchair or bedbound, or sitting down or lying down most of the time, has incontinence issues. So if they're incontinent of bowel and bladder, that does cause increased risk to the skin to break down, or they have other comorbidities, so something like heart failure, diabetes. Pressure injuries usually start small and grow. They deteriorate over time, especially if that pressure isn't relieved or the wound isn't treated. And especially if you have comorbidities, poor nutrition, et cetera, they can be difficult to heal. So it's important to catch them early on if you're able to. They are more likely to develop in a moist environment or where skin integrity is already compromised. So if you have a skin tear on a place that there might be some pressure, so sometimes the elbows and the hip, the tailbone, if you already have an opening to the skin, it is more likely to progress to a pressure ulcer because that skin is already impaired, and excessive pressure will cause it to deteriorate faster than, say, just your normal intact skin. So what to look for? It usually starts as a color change that doesn't blanch when pressure is applied. What blanching is say if I take the tip of my finger, if you take the tip of your finger and you press on it, you'll see that it kind of turns that whitish color, and then when you release, the color comes back and it's pink. If your redness does that, that means it still has good blood flow and it isn't a pressure ulcer, although you do want to keep an eye on it, especially if you see blanchable redness occurring in reoccurring spots. If it doesn't do that, that typically means that there is decreased blood flow to the skin and you have the start of a pressure sore. So you can see here, I've got a little diagram with the different stages. Stage 1, you just have that redness. There's no open area. It hasn't penetrated below the layer of the skin. Stage 2, you have a little bit of openness or sometimes a lot of openness, but it is still in that first layer of the skin. It hasn't penetrated to the fat, to the muscle, the bone. Stage 3 is where you start having more issues. That usually means it's penetrated down to the fat. you can start seeing more risk of infection, more risk of necrotic tissue, more drainage. So stage 3 is where we start having more trouble healing. And then stage 4 is when you get down to either muscle or bone, tendon. You've gone through all the layers of the skin and you're now at an exposed area of either muscle, bone, tendon, etc. And that is the most severe. These can be pretty difficult to heal, especially because when you get to the point of a stage 4, that usually means there's something else going on with the skin / the body that's making it break down more easily. So where to look for these pressure injuries? One acronym that I like to use is check the hot spots. So hot for heat, so H for heels. So if your loved one is in bed or sitting down a lot, those heels can be a place of pressure. So check the heels, make sure that they are, if they have redness, that it's blanching. You may feel a bit of what we call a boggy feeling if it's starting to break down, where it's kind of squishy versus, normal skin texture where it's nice and firm. The occipital, that's a fancy way of saying the back of the head. So right here. So if you're lying down, it's that portion of the head that hits the pillow first. The toes are also a place where we sometimes see pressure injuries develop. A lot of the time we see that if they're either on the side and that toe is kind of against whatever they're lying on. If you've got heavy blankets and the skin is very fragile, you can see some pressure there. If they're wearing some sort of brace. Sacrum, that is a fancy way of saying the tailbone. Posterior buttock / ischium, that's kind of like the back on your buttock towards the hip bone. Over bony prominences, we talked about that a little bit. Anywhere where you've got a particularly bony area. Sometimes we see them on the knees, the elbows, anywhere where you have a bony prominence that's hitting a place of pressure. The thoracic spine, some people's spines kind of jut out. So you've got that curve, and where that curve is hitting whatever surface they're sitting on. If there's not a lot of padding, you're at risk for breakdown there. And then the scapula, so the shoulders. But they can form anywhere. These are just some of the more common types. So if you see something that you think could be the start of a pressure ulcer or looks like a pressure ulcer, but it's not in one of these spots, it still could be a pressure ulcer. These are just some of the more common places they emerge. Prevention. We like to prevent things versus treat them. If we're able to keep it from happening, then that's wonderful. With pressure injuries, sometimes it's not always possible to keep them from happening, especially if the patient is predisposed towards them, is very sick, has extremely poor nutrition. We see a lot of pressure injuries develop with people, say, on hospice because they already are very ill and the skin is already struggling. But we can lessen the chance of them developing or worsening if they do develop. So checking the hot spots frequently. If you catch a developing pressure injury early, it often can prevent it from progressing and even start the healing process. If your loved one or patient has a pressure injury that has already healed, it is at higher risk of reopening because when a pressure injury heals, it doesn't fill in with the tissue that was there before. It doesn't rebuild fat or muscle. It just fills in with scar tissue. And scar tissue breaks down a lot easier than your normal skin. So checking those areas, if they've had a former pressure injury, checking them frequently to make sure they're not reopening. Frequent repositioning off of those hot spots or anywhere else that you're worried about a pressure ulcer developing. Typical golden standard recommendation is repositioning every 2 hours, but sometimes you do need that more frequently, especially if, again, you already have a pressure injury or a pressure ulcer, you are more impaired in your skin. It really needs to be individualized based on your patient or loved one. Keeping the skin clean and dry, particularly if your patient or loved one is incontinent. Moist environment equals easier for skin to break down, which, once that starts, it's difficult to undo. So keeping your loved one clean, dry, making sure their briefs are dry, and just keeping, as I said, clean and dry. Being gentle to the skin, so no vigorous rubbing when you're cleaning them, or because that, especially with tender skin, that can kind of start peeling off that top layer. If your loved one is bedbound or partially bedbound and you're needing to reposition and pulling them up, instead of dragging them, using a sheet to kind of almost lift them up as you pull them up or lift them as you're turning them. Be careful, of course, of yourself. Get help if you need to. Don't hurt yourself or your back. keeping the patient from sitting or lying on objects. So typically we see this if somebody has oxygen tubing or a Foley catheter with tubing. If you're repositioning your loved one or having them sit up, sometimes that tubing can get stuck underneath them, and that is an additional place of pressure. And we sometimes do see pressure ulcers develop because someone was sitting on their Foley catheter or their oxygen tubing. So just being very careful of that. Treatment. So as always with this caveat, if you see a new wound or what you think is a new wound and you have concerns, always reach out to your doctor and let them know, because they can provide more insight than a video on YouTube or a non-personalized presentation. If you catch it early before it opens, the most important thing is to keep the pressure off of the area as much as possible. So repositioning them off that area, again, every 2 hours or more often, using pillows or padded things to kind of push the pressure off or provide a softer area for that pressure point to be. For minor injuries, so in the early stages, not open, slightly open. Again, always notify your PCP when a new wound is found or an old wound is worsening. They can provide additional insight / individualized wound treatments with referrals to specialty services if required. Keeping the wound clean and dry. So cleaning it with soap, water, wound cleanser if you have it, and keeping it very dry. You can add a light padded bandage to the area to provide what I call artificial padding. So if you have a loved one who doesn't have a lot of fat, doesn't have a lot of padding, we can put artificial padding by using a padded bandage over that site, especially if it's not open yet. You can also add a barrier cream. I see this used a lot in areas like the sacrum, which it provides a nice barrier between the skin and any bodily fluids, so stool, urine, etc. I recommend Desitin for this. Some formulations of calmoseptine have menthol in them, and that can be very drying and irritating to the skin and can cause the skin to break down further. So this is a silicone foam dressing that I have some patients have used for padding the bony prominences. These are both available on Amazon, or you can find them in your local pharmacy. And then Desitin, again, you can get on Amazon, Walmart, Walgreens, etc. Okay, skin tears. So skin tears are another common one that we see a lot. It is a traumatic wound caused by mechanical forces. So typically you see it, you bumped your arm against something and your skin is fragile, so it tears. We also see it sometimes if you have like an adhesive bandage and the adhesive is pretty strong and you're trying to remove it. Older skin is very fragile, and even removing a bandage too quickly or too vigorously can cause it to rip. They vary in severity depending on how large, how deep they are, where they are. They typically occur in the extremities of older adults, so usually arms and legs, because those are the things that get bumped the most. For prevention, the most you can do is protecting the extremities from injury. So wearing long sleeves or long pants, using jerry sleeves, which are like a little fingerless glove that goes all the way up the arm. Padding rails, like side rails of the bed or wheelchair arms, anywhere where you think they could bump themselves. Using a lift sheet when repositioning. So again, kind of how we talked about using a sheet to help pull them up instead of dragging them up. Padding sharp corners in places where your loved one or patient is more likely to bump into, so sharp corners of dressers, tables, etc. And then if your loved one is walking and getting up on their own, ensuring areas where they may be walking are well lit. So if they get up in the middle of the night to go to the bathroom, having motion activated night lights to help them see and make sure they don't bump into anything. For minor skin tear treatment, so that's kind of, you've bumped yourself, you've got a little skin tear on your arm, it's bled a little bit. Cleanse the area with a gentle cleanser, so you can use soap, water, normal saline, wound cleanser if you have it. Patting the area dry very gently, so don't be rubbing vigorously, that can cause the skin to break down more. Just using a patting motion till it's dry. If it's bleeding, make sure you apply pressure until the bleeding slows or stops. If your loved one or patient is on a blood thinner, that can take a little longer than, say if I had a skin tear and was waiting for it to stop bleeding. If there is a skin flap, so sometimes with skin tears, that skin kind of gets pulled back and you've got a little bit of a flap where the skin was. Use a moist Q-tip to kind of push that back so that the edge of the flap is along the edge of where the skin where it got torn off. You can use what are called steri strips. They're like little pieces of tape. They're DIY stitches, but adhesive to keep the skin flap in place. You leave those on until they peel off. If you don't have a skin flap or you don't feel comfortable using steri strips, you can just use a bandage over the site, making sure there's no adhesive on the actual skin tear. Some people like to apply like a petroleum ointment. So your Neosporin, your triple antibiotic ointment, sometimes just plain old Vaseline to help keep the area moist and to provide an extra layer of protection for the skin. Again, don't put anything sticky over the skin tear. It can make it worse, especially if you're removing the dressing. As always, notify a patient's PCP for any concerns or changes. And then for larger skin tears or skin tears that just don't stop bleeding, they may require a trip to the ER or urgent care for stitches. Okay, abrasions. So an abrasion is a superficial wound caused by a mechanical process. So friction or shearing, basically two ways of saying like the skin is rubbing up against something. I liken it to road rash. So if you fell and skidded along the road when you were a kid skateboarding or roller skating, it's similar to that. With older skin, you don't need to fall on a road. You could get up from the couch too quickly and have it squirt. It frequently happens with falls. So you fall, your skin rubs up against something as you go down. Prevention is very similar to skin tear prevention. So keeping sharp corners or abrasive surface covered and padded, making sure your loved one or patient can see where they're going, and basic fall precautions. So making sure they're using their appropriate equipment like their walker if they need to get up and go. If you do have an abrasion, typically they aren't very deep. They're just painful. Cleanse the area with soap or water, saline, wound cleanser if you have it. Pat gently dry. Again, no rubbing. That'll cause the skin to break down more. You can apply the same thing, a petroleum-based ointment to provide a nice little barrier between the skin and the open air. And then often I will cover with a protective dressing or a bandage. If you have like those gauze bandages that, you wrap them up like a mummy, I like to use those because then you don't have any adhesive actually on the skin. You can just tape the gauze closed. And then of course, notify the patient's PCP. Lacerations. So a laceration is a torn or jagged wound typically caused by trauma, either blunt force, a fall, a deep cut. So these are the ones that you see, someone's cracked their head open or you have a really deep cut on your arm. It's like a very severe skin tear, a lot deeper. They can have minimal or heavy bleeding. A lot of the times I'll see lacerations that are on the head. Head wounds tend to bleed a lot more, whereas your legs, your arms bleed a little less. For minor lacerations, so your small ones, not super deep, not bleeding a ton, apply pressure until the bleeding slows or stops. Again, if your loved one is on a blood thinner, that may take longer than you or me. Clean the wound. Again, wound cleanser, soap, water, normal saline. You can apply an antibiotic ointment and then cover with a clean dressing. For lacerations that are on the face or the head, lacerations that are longer than a ½ inch, really deep lacerations, or lacerations that bleed very heavily, they will need stitches. Take your loved one to the ER or urgent care. And as always, notify the PCP. And then this is just kind of a little diagram on how to clean a wound. So if you have I'm going to pull out my wound dummy here. If you have a let's see. I have to fix it so it doesn't blur. But if you have a wound like this that's long, kind of like an incision or a long skin tear, you want to cleanse from the top to the bottom. Always wiping from a clean area to a dirty area, so cleaning like that. Using a new tissue or swab for each stroke. If you have an open wound like this, like this, you'll clean the wound in full or half circle. So you'll start from the center and work your way out like this, using a fresh gauze for each circle. So circle, throw out fresh gauze, circle, throw out fresh gauze, and clean to at least 2 inches beyond your wound margin. So this is more looking at either large abrasions, pressure sores, etc. Let's see. sources. A lot of this information was gathered from the workbook that I got from my wound care course, and I flip back to it frequently. And thanks for joining us. I appreciate you all being here. And I hope you have a wonderful day. Hopefully you won't have to use any of these tricks or tips or information, but if you do, hopefully this has been helpful. Thank you. Take care.